Well, if everyone is all set to go here, this is just a little prelude to the cadaver portion of this, this little get-together. Marcus Sciadini and I are going to go through, just try to show the various techniques and the things that you can do to enhance the exposure when you're doing an anterior intra-pelvic approach. And we're going to show the lateral window with the ASIS osteotomy just to show you the two separate kind of parts to the AIP, so you don't have to do the ilioinguinal and go through the canal. Not that there's anything wrong with that, but this is just another way to do it, and try to maybe just talk about some of the advantages of that approach versus traditional ilioinguinal. When we're doing the AIP here, the first thing is, we talked about it earlier, but you make sure that you have the ipsilateral hip flexed. So I put it over a triangle, a padded triangle or something like that, but I get it up fairly high, like maybe about 30, 40 degrees of hip flexion. And then lateral traction coming off here through the greater trochanter, coming out laterally and distally, sort of along the trajectory or the vector of the femoral neck. So those two things are really important. You got to get the femoral head out of the pelvis, and you have to really flex the hip. Flexing the hip allows you to maximize what you get out of this exposure because it relaxes the iliopsoas and it relaxes the external iliac vessels. And you'll see as we go through this exposure how much we have to retract those structures. If they're not retracted, if you have, for instance, if you have the hip extended and you have longitudinal traction, you're really tightening the iliacus and the iliopsoas, and it's going to make it really difficult for you to get in underneath, all right? So that's even before you've made any incisions. When you do the incision, your exposure, all right, is not really predicated upon a really big, wide incision. So at some point, you keep going really wide here, all you're going to do is get the spermatic cord or the round ligament. Your ability to maximize your exposure when you do the AIP, all right, is taking the rectus from here and flipping it and getting it out of the way this way. And the way that you accomplish that is you have to do three things, really. One is you have to split the rectus up fairly proximal, all right? So the getting the rectus out of the way is coming up very proximal, but also very distal. So when we come down here, some people, when they come in on the rectus, all they're going to do is just split the two halves of the rectus right down to the pubic bodies, and that's it. All right. What I think is really important to do is actually take the rectus, and I come off the front of the rectus, and if you got to remember that, right? Like if I take some of this fat away here, you can see how far down the rectus muscle inserts on the front of the pubic body. It goes all the way down to the bottom of the pubic body. You don't want to transect it this way, but if you keep releasing it off of the pubic body from the midline and then coming across this in this direction and coming down the front of the pubic body to some degree, you can already see, how much more I'm able to take the rectus laterally over towards the side of the injury, all right? I'm still leaving the rectus attached distally and anteriorly on the pubic body. We're just kind of feathering it off, some of it, so that we can get it to retract laterally a lot more. So it's not stuck and tethered here at the midline. All right. Another thing you can do is release a little bit of this side over here in some bigger people to try to get this rectus out of the way, and that helps to improve some of your exposure as well. All right. So the first two things we talked about, high split in the rectus here and low release of the rectus off the front of the pubic body here. Okay, that's number one. Number two. Number three is this. So when you come in at first, just come on out with that for a second, Mark. Mm-hmm. When you first come in and you get into the retropubic space of Retzius right here, all right, when you come in, you're going to take your finger and then you're just going to come in underneath the rectus muscle like this and break down any adhesions between the bladder, and the undersurface of the rectus. And the reason you want to do that, make sure you do a good job of that, is as we're trying to retract rectus towards the side of the acetabulum, we don't want it to pull the bladder and any of the pelvic viscera that way. We want the bladder to stay over here and want the rectus to go over there. All right, and so by kind of breaking down some of those adhesions on the undersurface of the rectus, it helps you accomplish that. All right, so you'll see here, and you know, I'm not one to say that one exposure is better than the other, because I think that you should choose the one that works best in your hands. But the one thing that is nice about the AIP approach is that you can see really nicely right here. This is an anastomotic vessel right here coming from external iliac down over the brim into the obturator foramen. So that's, I guess, I wouldn't call this a corona mortis, because if this one bleeds, it's pretty small. It's not going to be a problem for the patient, but it is one of those little anastomotic connections. You have to take that away in everybody. You can't possibly do this operation or this exposure without taking that, either ligating it, buzzing it, cutting it, whatever. So just like the ilioinguinal, you're going to have to deal with the iliopectineal fascia. This is the reflection of the iliopectineal fascia right here. So when you do an ilioinguinal and you start with window number 1 over here and you start working your way this way, the way that you get from the false pelvis into the true pelvis is you release the iliopectineal fascia. We come down through window number 2 and cut it and take it off the ramus. When you do an AIP, it's just the reverse direction. We're starting in the true pelvis, and then we're going to come here, and the only way for us to get into the false pelvis up here, and take a dever and just retract that up, the only way for us to get into the true, or from the true pelvis into the false pelvis, is to release this iliopectineal fascia right here. All right, so I'm going to come along like this. All right, and I'm going to carry that. I'm going to carry that incision and carry it and continue it to what I'm doing with the rectus muscle. And so a little bit of muscle fibers you see under there, that's the pectineus muscle. All right, and so we're going to just take the iliopectineal fascia off the superior pubic ramus. Usually you'll see a fracture line right here at the beginning of the pubic root. Right, remember that the front of the pelvis here, I'm going to put a K-wire just to hold this skin out of the way so it's easier for you all to see.
Do you want to put our lighted retractor in?
Yep. And we're going to put some retractors in here now. So you can use either sharp Holman or this retractor number 1 from this set. We have another threaded wire.
Yep, I had one up here. I had one up here. I had them both up here. Oh, here
Can
it is.
you zoom in a bit on that, please, Jason? So these wires will just kind of hold the retractor in place. All right, so you can see how we've got some pectineus muscle fibers here, and then now what we're going to do is we're going to work our way across the pelvic brim, and we're going to get ourselves up into the false pelvis. So right along here, so if we just actually take this, if we take this retractor, and just kind of, I'll just show you, because there's a mistake that some people make in terms of what they think they're looking at. So there we go, that's a better view there. So this here, that dark structure that you see there, that is not the external iliac vein. That is the iliacus muscle. All right, when people see that, especially when there's hematoma in there, they get a little scared and they think that's external iliac vein. The external iliac vein is on top of it right here, and it's loose, and you can see external iliac vein right there. So it's really important to kind of figure out what you've got and what you're retracting. So when you're the guy putting the retractor in, you really want to make sure that you get in underneath the external iliac vein like that. All right, and so now you can see that we've got, this is now iliacus fascia along the brim that is the same layer of tissue that communicates with the iliopectineal fascia. So we're just going to kind of come in here like this. All right, and I'm just going to release iliacus muscle off the pelvic brim, and what we're going to do actually is we're going to take it all the way up over these hills and valleys. So you got a hill here, that's the pubic body. You got a valley, that's the superior pubic ramus. And then you got a hill again, that's the pubic root, or the pubic, the eminence. And then right on the other side of that is the psoas gutter. All right, so you can see how the cob falls in there like that. So that is where you want to get out to, because that's a good place to put your next retractor, is you get in underneath psoas into the psoas gutter. All right, it's kind of at the base. It's kind of at the base of the anterior wall, isn't it? So the next part of this is going to be coming up into the internal iliac fossa now. So we're going to come up this way. All right, now we're going to come in underneath this. That's all iliacus, iliacus, iliacus. Oh, what happened? There we go. All right. And so what we're going to do now is we're going to take the cob. We're going to take the cob, and we're just going to slide it up the internal iliac fossa. And this is going right lateral to the sacroiliac joint. And you're going to see here that you're going to come. Do we have a pelvic model, actually? Can I see that pelvic model? So let me see if I can come in here. Can you zoom out for just a little bit on that? Thanks. So basically that cob in this retractor, we're going to come here, and we're coming up, and we're coming just lateral to the sacroiliac joint like this. And this is basically what we're exposing right here with this AIP approach. So this retractor, this malleable, is going to come right here, basically right to the front lateral portion of the SI joint, and push the pelvic contents away. So this is going up and in, and that is coming right there. So I'm not sure if we can take the, that's actually pretty good right there. That's nice. All right, so this is the point at which you're going to take this neck. You've got a couple of options here. So you can use a malleable retractor, and you can just slide it up and pull it up like this. All right. The other option is you can use that number 3 retractor and slide it up in the same position, just lateral to the sacroiliac joint. And so this retractor is placed underneath the iliacus muscle. All right, and so yeah, we need to.
Your head, Claude. Your head. There you go. There you go.
Oh, that's not too bad. So and so you'll notice on this retractor here that it has 2 K-wire options, I guess, if you want to call it that. And depending on what side, it doesn't mean you need to put 2 in there. I guess you can if you want. But basically, if you're on the left side or the right side, you're going to put 1 in. If you're on the left side, you want to put the K-wire, stabilizing K-wire, into the hole that's most lateral. So if you're on the right side over here, I would use this one. If I'm on the left side, I'm going to use that one. And the reason it is for that is that when it comes time to putting the brim plate on here, it doesn't matter what type of plate you're using, any brim plate that goes along here, if you're in this one here, sometimes that wire will interfere with your ability to put a brim plate on. So it's nice to use the more lateral of the 2 options to help retract that and not have a K-wire interfere with your ability to look in on that. All right, so I'm going to slide this up just lateral to the sacroiliac joint. All right, and I think what's happening is you're rotating the patient. All right, so we're just going to might block your view for a second here, but just going to put this other stabilizing K-wire in. All right.
Do we have that light on also? Yeah, I think so. Yep.
Okay. Good. We can probably take that one out. The one advantage to these retractors is that they have lights that you can, fiber optic lights that you can hook up to them, so you can really, there you go, that's a pretty nice view right there. So you can really help to just improve the lighting inside the wound there. So that takes up, that's the kind of the first half, or the part A of this whole dissection, is getting into the internal iliac fossa. And you can see right here, that's I'm lateral to the sacroiliac joint right there. That's the front lateral portion of the sacroiliac joint. So we see the brim from here all the way to pubic body and pubic symphysis, right? So you can see how you can actually fairly easily get screws in for an anterior column plate or anterior column buttress plate or suprapectineal plate. You can see all the way back here from that. All right. Next part is going to be coming down the quadrilateral surface and exposing the posterior column and quadrilateral surface from this exposure. The first part of doing that is finding the obturator nerve and dissecting and releasing the obturator nerve. All right. And the Archdeacon / Guy initiative of treating the obturator nerve is number one, release it from the obturator membrane right here so that you've got some play in the obturator nerve right there. The other reason that's a really good idea to do that, I really like doing that, and I thank Mike for enlightening me on this, is that this, even in elderly people who have, not so great bone, when you're trying to reduce the anterior column, this is a great place to put the tine of a retractor. You push the obturator nerve down out of the way, and you come into the top part of the obturator tunnel right here, and you put a clamp right there and another one up here in the pubic emmets, and that reduces the lower part of the anterior column fracture. So even in people who have bone, even in people who have not bone that bone that's not so great, that's still good quality cortex that you won't puncture through, unlike here. The other part that Pierre Guy likes to talk a lot about, and that is also really important, is releasing and tracing the obturator nerve up as proximal as you can get it. Because what this now allows you to do is work on both sides of the obturator nerve. When you're up here, you're going to be medial to the nerve. And then as you work your way down the posterior column, at some point you're going to be stretching the nerve too much. You see that? So I'm going to want to come in underneath, and I'm going to work down here now. So that's why it's really important and critical that you come in and you really release the nerve well, because now I can dissect with impunity along the medial surface of the posterior column and the quadrilateral surface without doing anything to the obturator nerve. And you're going to take this release of the obturator internus muscle here, all right, you're going to take this off the quadrilateral surface all the way down to here. It's going to be really hard to show it on the camera, but this is the ischial spine. So I'm down to ischial spine, and if you watch my cob right there, you can see it fall in to the lesser notch.
Maybe switch back.
Okay, so ischial spine is really pretty much the base of your exposure, and then back here, I'm going to put the malleable back in now. All right, and what's happening here now is I'm in the greater notch there. All right. Now, people in the greater notch, people get a little worried about the greater notch, and you should be. You got to be careful when you go in here because you've got superior gluteal nerve and artery. But the other thing that you really have to remember is that the hip is flexed. And the hip is flexed, the sciatic nerve is under a little bit of tension. So that's just how you get sciatic nerve palsies when you do an anterior approach. That was a paper that was written by Heidekevich many, many years ago. It was more for ilioinguinals, but it's still applicable here. And that is that if you start doing a lot of things in the greater sciatic notch without really being careful, you can actually hit the sciatic nerve, and it's under tension. So just be careful. I put retractors and reduction clamps in the greater notch all the time, but you just have to be careful because you can get sciatic nerve palsies back here, all right? So that you can see how we got exposure all the way down to the ischial spine. We see the entire medial surface of the posterior column from the greater notch, which is right there, all the way down to ischial spine, which we can't really show you with these camera angles. All right, right up to the obturator foramen. So entire quadrilateral surface and posterior column. We haven't even done anything yet other than our little fan and steel incision. That's the lateral, that's the anterior margin of the sacroiliac joint right there. All right, and with this nerve nicely released like this, you can easily put an infrapectineal plate right here. You can put the suprapectineal plate here with the quadrilateral surface buttress that comes along here like that. All right. And it gives you a lot of options. The other thing that people don't often think about but is really good is that if you have a very high transverse or T or any fracture that's high in the posterior column that exits up close here by the notch, you can see how you can do a posterior column plate from here all the way up here, coming up into the iliac fossa. So it's a posterior column plate like you would do externally, but we're doing it internally instead. And you can put screws all along the posterior column here, and it's all posterior to the acetabulum. This is not aiming into the acetabulum. Guy here has got a good paper on the safe zones, and with this approach on kind of looking at your landmarks and where you're aiming into the joint and where you're not aiming into the joint. Fortunately, the trajectory that the soft tissues force your hand to be in actually aim you away from the joint in most of these cases. So this is all a nice safe zone for screw purchase. And if your fracture is high enough, you can easily plate the posterior column from inside the pelvis. All right. Mike, that's pretty much it for that I want to show on the AIP here. Except for the, yeah, right. Sorry, I forgot. Hang on, Mike. So this is the suction retractor that's kind of nice to use. And the one thing about doing this exposure is that fluids, especially blood, tend to pool in the base of the wound as you're doing this. And so this retractor is nice because it does two things for you. Because of its shape, when you put it in, it pushes the bladder away and really opens up the exposure of the posterior column for you, as well as the quadrilateral surface. But it also has a little suction device at the base of it, which helps to remove the fluids that accumulate at the base of the wound. You can do a number of things with this retractor. You can put it into the greater notch. You can lean it up against the posterior column or the lower part of the quadrilateral surface, or you can even go into the lesser notch with it right there, depending on where you're working and what you want to see. So that's kind of a nice little tool that you want to do. And here's a demo. Look at all that blood.
Listen to all that noise.
Ah. Very nice. Okay, there you go. So, Mike, are there any questions about anything on that exposure?
Any questions for Dr. Sagi or Dr. Sciadini?
You've dumbfounded them, Claude.
Yes. All right, well, if that's the case, then what we're going to do is we're going to go over to the other side of Marcus, and he's going to show you the advantage of the ASIS osteotomy and the lateral window. No questions at all? Yeah, it's very disappointing.
Too thorough in your explanation.
Okay.
All right. So, the lateral window, the standard lateral window is a pretty straightforward approach where you're just basically coming down on the iliac crest from the ASIS, following the pelvic brim across up until a point, and you sort of curve a little bit more cephalad at some point proximally where you end up actually coming through more in the way of muscle fibers as you get more proximally. If you keep following the pelvis around posteriorly, then it puts your retraction of the soft tissues under a little bit too much tension. But the standard approach is really very simple. There's not a whole lot of nuance to it. You just come down on the crest, and then you do a subperiosteal dissection off of the iliac fossa down to the SI joint. The modification with the ASIS osteotomy is something that you have to decide pretty much early on that you're going to do, because if you make your standard lateral window and you take all of that tissue off of the iliac crest early, then you've kind of pooched your ability, or at least any advantage that you're going to get out of an AS osteotomy. So the incision you make is a little bit modified. So instead of, the way I have done my Stoppa and lateral window previously has been to just do a full ilioinguinal incision rather than two separate incisions. But if you're going to do the ASIS osteotomy, it makes sense to keep the incisions separate. So you do your fan and steel in here, you do a standard lateral window incision here, and then curve it down distally in a little bit of a almost Smith-Peetish interval extending down from the ASIS down along where the interval between the tensor and sartorius would be. So if you do that, then you incise your fascia and you find that interval and develop that between sartorius over here more medially and tensor fascia laterally. And then you take your soft tissue dissection then off laterally a little bit more from here proximally. down along here distally. And what it'll let you do is get into the interspinous notch, which you can pass. You can feel with your finger. It's very easy to feel right in here. You can see it. You can pass a clamp through there, and then that gives you the point that you want to aim your osteotomy at.
Marcus,
Yeah.
can you just go over how much of the, it looks like you got about, what, 3 centimeters of external oblique that's remains attached?
Right, from pretty much here to here, right? And you definitely want to keep that, it's, you know, essentially about 2 finger breadths. You want to keep that attached because that's the 2 advantages of this is, one, it takes all the tension off of your abdominal fascia and your abdominal contents because it all just goes with the bone, and it also protects your lateral femoral cutaneous nerve because it goes in there as well. And you can see we had exposed at least one small branch of that, as you can see right here, that's still contained in your sartorius with the ASIS osteotomy. So it also sort of protects that nerve to some extent. So what you want to define where that interspinous notch is, pass something through there, and then you can just aim your osteotomy at it. And I tend to try to do it almost as a L-shaped or a right angle osteotomy so that you have kind of a nice corner to reduce at the end, but you don't have to. You can use a curved osteotome and make it almost sort of a semi-lunar. It ends up being, because it's a digastric osteotomy, it ends up being very stable and you have less of an issue in terms of it pulling off. And I haven't seen any of these come off after fixation. I don't think you have either, have you, Claude?
Nope. You, Marcus, do you pre-drill your osteotomy before you do it?
I don't usually. Do you?
Nope. How do you fix it?
With a single screw, usually, just a single 3/5 screw is all it usually takes. Sometimes your fracture will involve some of that, and that you may have to get a little inventive with your osteotomy when that's the case. But here you can see, where's your God? Now, all of a sudden, your lateral window opens up like crazy. Where's that sharp Homan? So I'll slide my sharp Homan down, feel it just kind of go over that anterior ridge of the SI joint, and I'll stick it right in the SI joint and bring that over. And then I'll usually put something like a Cobra over the brim here. But all of a sudden, just by having that ASIS osteotomy, your exposure out here distally is tremendously expanded, right? I mean, you're way down on anterior wall now, okay? You're over the brim from above, and you know, as much as you can see with an AIP and a standard lateral window, this osteotomy opens it up like tremendously. It also allows you another quarter to pass a clamp because you've opened up into this interspinous notch, which is right here. It opens things up to where you can actually pass a clamp around the outer table if necessary, and you're not blocked as much by the abdominal fascia and abdominal contents.
Marcus, what are the indications for you to do this?
I mean, it's becoming more and more routine for me, to be honest, if I'm going to, because most of the things that I want the lateral window for are only that much easier with the osteotomy. For example, getting my anterior to posterior column screws in, that trajectory is facilitated. You're not as limited by where the actual holes in your suprapectineal plate are, but you have more options for some independent posterior column screws. It gives you a better shot down medial to the joint. It just gives you, I think, a lot more flexibility in terms of where your fixation corridors can go. And certainly if there's an anterior wall that's a significant component of your fracture, I think this is very useful. You can get at those anterior wall fragments from below as well by incrementally releasing the rectus and rolling it out. But the bigger or fatter the patients are, you may be limited in how lateral you can get through the AIP, and this ASIS osteotomy will get you there from the other direction.
Do you use that when you're doing if you're doing an anterior sacroiliac fixation for a side dislocation? Do you do that now?
I haven't had the occasion to, but I think I would. It certainly gets you in there. If I were going to plate an SI joint, I think I would definitely give it some serious consideration, because it just opens things up so much more. I think another place where it might be useful is when you have those sacral ala fracture dislocations, where you have a sort of anterior lateral fragment of sacral ala that's dislocated from the SI joint and flipped out. You know, a lot of times that reduction through a standard lateral window is a little bit blind, which is nerve-wracking because of the L5 nerve root, but this would get you much better visualization of that, I think, to flip it back in and reduce it before you put in your fixation.
Yeah. What about contraindications to this approach?
I don't know. Are there any that you can think of, Claude? I mean, other than where, you know, if your fracture line really extends up in here, if you've got both columns where you have a lot of iliac wing comminution, it may not, you know, you may not want to create yet another fracture line, but I don't know that that would even be a definitive contraindication.
I don't know. For me, I kind of use the anterior margin of the iliac tubercle as my guide for that, because the one other thing that you have to keep in mind when you do an osteotomy here is the blood supply to this iliac wing fragment. So, you know, especially if you're going to be coming down on the outer table and maybe taking a little bit of the abductors off. Sometimes if you have a very anterior fragment, sometimes the insertion of the rectus and the sartorius are really the only remaining blood supplies to this anterior column fragment. And so I would be a little wary of doing this osteotomy if there was no iliac tubercle left to the anterior column fragment. If there's iliac tubercle here left attached to the anterior column fragment, that's the insertion of tensor fascia, and you still have a lot of blood supply to this whole iliac wing fragment. But as that fracture line starts to come more anterior, like in an anterior column posterior hemitransverse, then I would start to shy away from this, because I'd be too worried about devascularizing this segment, the fracture lines anterior to the iliac tubercle. I haven't done any like, you know, those stained blood vessel studies to see how that affects it, but that's just kind of my own rule of thumb.
There's another position here. You can park a blunt Homan or a Cobra type clamp up over the very cephalad and medial aspect of the iliac wing that can help get you to some of those either very small crescent type fractures or very proximal medial iliac wing fractures that are part of a both columns fracture pattern, and you can slide a clamp over there to get you better access to that for reduction and putting a plate across. So that's often a very difficult place to get. But you can, this I think facilitates getting you there as well, just because it detensions all that soft tissue attachment.
Any questions from the audience? Yes, sir.
Why do you prefer an osteotomy as opposed to just with soft tissue release?
Marcus, the question is, why do you prefer the osteotomy over just a soft tissue release? Just cut the sartorius.
I mean, I think it accomplishes the same thing probably in terms of exposure, but I find, for me at least, fixing the osteotomy is easier and more reliable in terms of the repair. Claude, do you have any thoughts on that?
Well, I think it's more of an anatomical reconstruction. You know, you're not releasing soft tissues away from the bone. So if you're having to try to repair the soft tissues back to the ASIS, I think that you're less likely to have a successful repair there, and more likely that that's going to fail. Versus, I just think it's a more of an anatomical dissection, and definitely more of an anatomical repair that's more reliable.
Also
right.
protects the lateral femorocutaneous nerve.
Exactly. Yeah, you're right.
Other questions? There appear to be no other questions,
Okay.
so
Come on
we'll
in. The water's
meet you
warm.
guys in the lab. Thanks a lot.